Okay, Dr. Enrique, you may begin.
Thank you. Um, Welcome to our last of this series of webinars, the Latino Health Forum, the 28th um, Annual Health Forum, Discrimination and Health. With the pandemic, we've been seeing more clearly than ever how there's a terrible, deep, prevalent um, epidemic discrimination and access to health. So because of that, there are people of color are dying and getting sick and losing everything a lot more than other groups, especially whites. I prefer not to use whites, but a friend of mine once said whites, and he says, I never called you brown, why you call me white? But well, today we are very lucky that we're closing this week, these 7 days, with a wonderful speaker that when I saw her, I thought she was a resident. She's so young. Is Dr. Sharon Washington, that she's going to talk about racism and COVID-19 navigating the two pandemics, the trauma of two pandemics. And yes, as you know, pandemic is when it's not limited to one country or one area, but affects the entire planet. So there's two pandemics, yeah, the racism and the COVID-19. Dr. Washington, she's an EDD MPH, and she is consulting at Sutter, Santa Rosa Family Medicine Residency. Dr. Washington is renowned for engaging diverse audiences on the complex intersections of race, historical trauma, social inequality, and justice, and the impact of these factors on health outcomes. And it's very clear that that happens. For the last year, Sharon has spearheaded transformative organizational changes with the Sutter Santa Rosa Family Medicine Residency in Santa Rosa. Through this partnership, she has coached the executive team of the residency to cultivate a cultural shift of transparency and inclusion of diverse residents, faculty, and staff. For many years, the residency was white young men, and in the last 10, 15 years has been changing dramatically. In fact, now we have a lot more women. Fortunately, women are the natural healers, and different colors. So, but that brought some problems, some issues, and we're so lucky to have Dr. Washington helping us at the residency. And I really took the time to be here because she's a very busy person. So please welcome Dr. Washington and enjoy the talk, and please questions at the end. We'll be happy to respect the timing. Thank you, welcome.
Thank you so much, Dr. Enrique. Good afternoon, everyone, and thank you so much for having me and allowing me to wrap up this 7-day series. So in our session, I'm going to contextualize the construct of race and just sort of unpack the ways in which structural racism and elements and manifestations of structural racism are influencing and impacting health outcomes. I'm going to particularly focus on anti-Black racism, and I think when I explore some of the historical context of its creation, that will make sense, but I want to just name that so that people don't feel like they're being, marginalized or ignored as I'm really centering the conversation today on anti-Black racism. And then I'll be able to offer some insight into racial trauma and the ways in which that's having implications on communities experiencing racism and discrimination, particularly from an African American perspective. So I thank you for holding this space to include and even centralize African American experiences within the Latino Health Forum discourse. So I will express that I've squeezed quite a bit of content into this 50 minutes, so please do forgive me if I speak kind of quickly. But to get started, I want to introduce and define racism. Oftentimes, when we talk about racism, people will immediately think about, interpersonal degradation or disrespectful remarks towards a person based on their race. And that is one component, one type of racism. But I'd like to just explore some other levels of racism that are really important. So structural racism is increasingly being spoken of and being, highlighted and addressed in the ways that we're experiencing community uprisings, protests, but also just ongoing activism around addressing and undoing racism. And so structural racism has to do with the systems of policies, institutional practices, cultural representations and norms in our media, in our formal and informal education settings, et cetera, that reinforce racial group inequity. And so we will talk quite a bit, especially in looking at what has contributed to the creation of race as a social construct, the ways in which structures within our society, the governing institutions that we have to navigate in order to have access to housing, education, healthcare, how racial group inequity has been designed into the features and the functioning of the structures that we have to navigate as citizens of this country and as citizens of the world. Institutionalized racism speaks to the ways in which individual institutions work and function to perpetuate racial group inequity through biases in hiring practices, in promotions, in evaluations and assessments, in termination practices, in pay gaps and inequities. The ways in which racial group inequities are perpetuated by institutions and the policies and norms within those institutions is key. And then that interpersonal racism that I described, that oftentimes is what comes to mind. And often in healthcare in particular, the interpersonal racism, certainly there is some level of conscious, intentional, explicit bias. But more often than not, interpersonal racism, especially in settings like healthcare and oftentimes in the workforce, have more to do with unconscious biases and the perpetuation of stereotypes that happen through what are called racial microaggressions. And so these subtle, oftentimes unintended slights that people are less than aware of the harms that those kinds of statements or insensitivities are perpetuating on people of racially minoritized and marginalized identities. And then another important element of racism is that of internalized racism. So the ways in which people of racial minority identities absorb, internalize, and believe in the devaluing and the stereotyped sort of representations of people of their group, and therefore might contribute to stifling their own potential, as well as what's called horizontal oppression, where people may impose oppressive behaviors and violent behaviors towards people of other marginalized identities. And so as we start to unpack what is race, I want to make sure that we're clear about the definitions of racism so that as we see how race has been constructed and embedded within our institutions and within our systems, we're able to function with this landscape of definitions. So oftentimes people have heard the phrase that race is a social construct, not a biological construct. And I would say definitely in the last 10 to 20 years, increasingly within professional settings, people have become accustomed to at least acknowledging that the Human Genome Project has taught us that there isn't anything significantly scientifically different in the body formation and what makes us human beings between people in the category of white versus people in the category of Black. But oftentimes what I've noticed is that while people will put this language out, race is a social construct, not a biological construct, we rarely ever hear or learn about, well, then who constructed it, right? That means that it was an idea that people generated. Well, who are those people? And why did they generate this construct? And why do we still function with it now? And why do we use it as a scientific variable in our research study if there isn't something scientific about me checking the black box that's going to affect the way that my heart beats or that my blood flows, right? So really taking the time to make sure we're unpacking what does it mean that race is a social construct, and what is the context that has led to creating an idea that has had such long-lasting, significant implications for individuals and groups, particularly as it pertains to their health. So then what is race? Race is not a biological feature as part of our genetic makeup per se. It's a political construct. It's a way of grouping people together and then determining the value, the access, the potential for opportunity, for growth, for life, for liberty, depending on which grouping people are assigned to. It's a false classification of people that's not based on any real, accurate, biological or scientific truth. The people who contributed to constructing this identity of grouping people in this particular way, they didn't do genetic testing back in the 1600s. They didn't do any blood tests to confirm their ideas about how people have come into formation and grouped as communities. It's instead a classification for human beings that has been designed by the people who designed it and wrote about the process of designing these ideas to give power to people who were defined as white and to legitimize the dominance of those white people over non-white people. And I think it's useful to keep in mind that at the time that this idea was being constructed and that policies and practices and laws were then reinforcing this construct, that many of the people who are considered white today were not white at the time, including Irish people, Jewish people, people from European countries that immigrated to the United States. And so keeping in mind the historical context of who has been allowed to be white and at what expense is an important conversation for another day. So unpacking the idea that race is political, Dr. Dorothy Roberts from University of Pennsylvania has written extensively about the use of race in medicine and healthcare and science and genetics. And she describes that the very first step of creating race, dividing human beings into these categories, has been a political practice. It's a very real political grouping mechanism that has actual consequences for people's health, wealth, social status, reputation, and opportunities in life. And despite the fact that dividing people into races has biological effects because of things like segregation and marginalization and income and wealth inequities, slavery, for example, that doesn't change the fact that this form of division was in fact a political exercise and not something that reflects true biological difference. So as we think about the origins of race, who are the people who came up with these ideas? One of those contributors, just one of many in, over 100 years of people, leveraging science as it emerged and religion as it was interpreted. Many people have contributed to the formation of this idea of race. But one of those was an explorer named Francois Bernier, who in 1684 wrote as part of a text he called A New Division of the Earth, letting you know that splitting people up into this categorization of race was intended to divide, right? That he says in what I think of as the longest sentence in human history, maybe not factually true, but it feels like it. He ultimately describes, for although men are almost all distinct from one another as far as the external form of their bodies is concerned, especially their faces, according to the different areas of the world they live in. And while they differ so clearly that people who have traveled widely can thus often distinguish unerringly one nation from another, nevertheless, I have observed that there are in all 4 or 5 types of race among men whose distinctive traits are so obvious they can justifiably serve as the basis of a new division of the earth. So he's saying, although every single individual, perhaps aside from identical twins, looks markedly different from one another. If we opened up the gallery of who is in this call and turned on our cameras, we all look distinctly different from one another. There's diversity there. that you can also then see that across regions in this world, you can kind of tell Eritreans from South Africans who look different from people in this region of Japan, right? So there's a lot of regional diversity. But even though there is all of this immense diversity in the human population, I'm going to go ahead and lump everybody into about 5 groups. That's the level of rigor, scientific thought that went into creating the very boxes that we still use when we fill out a loan application, when we fill out a college application, when we fill out an intake form at the hospital or the clinic, right? So then it's important to think about, as race was constructed without any significant, conceptualization or exploration of if there's real biological meaning to creating these groups. It was really based on observation and then morals, values, and a desire to leverage the resources that European explorers were finding that indigenous people around the world had access to in the land masses where they had occupied for thousands of years. And so really having the creation of race be driven by an economic desire to bolster the economic status of Europe and the explorers who were coming from Europe and finding not only resources and land around the world, but the people who inhabit those spaces. And so keeping in mind this economic drive for exploration and also for defining groups of people that largely had to do with dehumanizing people so that it was justifiable, especially through the lens of the religion that was prevalent in Europe of Christianity, to sort of justify treating people in dehumanizing ways, in subjugating ways in order to leverage their resources, but still being able to consider one's group holy in the eyes of their religious practices. And so keeping in mind that chattel slavery and the history of human life, that many societies experience slavery. Oftentimes when there was war or conflict, the people who would be captured in battles would come back to the winning group's community and be indentured servants, or perhaps they would be integrated into the community in various ways. They could oftentimes marry into communities. But the chattel slavery that was experienced through the transatlantic slave trade from West Africa to the South and North Americas and to Europe, this triangular trade represented a shift in human history that produced some of the most violent acts of slavery that humans have documented. And that included that slavery became not only a function of indentured servitude for a certain amount of years or until a person integrated into the community, but it was lifelong subjugation, not only for the individual, but for the offspring of that individual. There was also an extremely high level of violence all throughout the process of slavery. And when we think about the health implications of the descendants of this legacy, it's really important to maintain that context because it's not far removed terribly from where we are today. Harriet Tubman, she passed in 1913. That was the same year that Rosa Parks was alive. I was alive while Rosa Parks was alive. And so we are one lifetime removed from Harriet Tubman walking this earth, right? Keeping that in context. And so, that's really important. And then the ways in which manifest destiny, this idea that settlers in the West, in the, east part of this country were mobilized and ordained by their notion of their God to take over the rest of this land, push people who were indigenous to this land west, to see them as enemies of their Christ and be able to cause harm, devastation, and even adopt governmental policies and practices such as kill the Indian and save the man. And so the implications on indigenous populations to America for that legacy of 500 plus years of subjugation, land stealing, mass genocide and cultural genocide is pertinent to the health outcomes that we see today within the community. And so this just sort of outlines, even today when we look at the picture of income inequality and wealth inequality and the gaps in our economic experiences and realities across racial groups, that looking at the lifetime earnings of people who are between 58 and 62 years old, that in 2016, You know, we think about people who make less money, people who earn less money have a harder time saving money. And if you don't have money saved up, then you have less to pass on to your next generation, you know, making it harder and harder to navigate situations like a pandemic where people lose their jobs, or, you know, have to be able to have savings in order to pay rent when things like this are going on. That the average white man earns $2.7 million in their lifetime, compared to the average Hispanic man earning $2 million and the average Black man 1.8 million. And then looking at the grave disparities across gender, right? And so for 2.7 million for a white man, we can see Latina women making $1.1 million. And then when you think of the communities that disproportionately experience families that are led by single parent, single woman households, that you see how intergenerational poverty and lack of opportunity that is contingent on wealth accumulation and income accumulation becomes hyper concentrated over generations in particular communities of color. Also looking at the wealth gap. So there's the income that then contributes to wealth. And we see that white families accumulate more wealth over their lives than Black or Hispanic families do, which widens the wealth gap as people get older and across generations. And so by 2016, the families that were at the top of the percentile, people who made more than 99% of all other families. By 2016, they had 12 times the wealth of families in the middle percentiles of our society. By 2016, the average wealth of white families was $919,000, which was over $700,000 more than the average wealth of Black families, which was about $140,000, and that of Hispanic families, which was on average $192,000. So keeping in mind that it's not only the income that families have, because income is susceptible to things like a pandemic, an economic downturn, et cetera, and it's that wealth that offers people the foundation for sustainability and for growth, and that historically has been deprived of groups of people. So then when we consider science, what is the role of science in creating race and giving it value? So as the scientific method has emerged, as scientific thought, categorizing, you know, species into groups, whether that's animals, plants, etc., that different forms of pseudoscience have been generated to reinforce the idea that race is biological, that Black people, people from Africa, are markedly different and subhuman to those of white folks, people of white identity, and that false biological justification lends itself to then being able to treat people as less than people and abuse them for their labor, abuse them for their lands, rape, maim, and terrorize for centuries. And so we see that in theories like evolution, holding the idea that African people are a subhuman species that's more connected to apes, and that Europeans reflect the evolution of human beings, using that as justification for treating people of African descent as less than human beings. Phrenology was the pseudoscience of studying different sizes of skulls and you know, selecting people from, you know, groups within Europe that are very large-bodied and comparing them to very small-bodied African tribes and saying Africans have smaller heads, so they have smaller brains, so they're less intelligent, so they should be dominated by the more intelligent group. And having IQ, you know, build upon that concept, and eugenics being an entire field of regulating reproductive rights and access for people who were deemed socially inferior, people with mental illness, people who were homeless, people who were Black, Puerto Ricans, and there is a legacy into our recent modern history of practices that in the Black South, they called it a Mississippi appendectomy because of the ways in which women would be, you know, sterilized without their consent. And so we'll talk more about medical mistrust when we talk about some of the trauma within healthcare specifically. We see it in politics, from putting into the governing document of the Constitution that Black people will be counted as 3/5 of a human instead of a whole human, thereby codifying into our laws and our governance the dehumanization of Black people. Having the Virginia Slave Code of 1705 that says that if you kill your slave while you're punishing them, that's not a crime. Literally decriminalizing the killing of Black people. And so we have so many generations of laws and policies and the functional use of politics to marginalize and subjugate people of color, particularly Black folks in America. One use of politics has to do with the ways that housing has been impacted. And so in 1976, 68% of white families owned their homes, compared to 44% of Black families and 43% of Latino families. By 2016, the homeownership gap had narrowed slightly for Latinos, but had widened for Black folks. And Black and Latino families were also less likely to own homes than white families of similar socioeconomic status. And so again, the ways in which when we had the GI Bill after, I think, World War II, that veterans got to come back and invest and be supported by the government in purchasing suburban houses to create a middle class. There were, and you can find in some of the houses in this area specifically, in Santa Rosa, policies that say that you cannot sell this house to a Black person. And so having that codified into policies and into laws, that we then still continue to inherit the disparities that were created at that time. And when you couple that with policies like redlining that perpetuates segregation in housing policies, that influences health outcomes and wealth inequities, and then having concentrations of lack of property tax when people of color disproportionately are deprived of access to owning their homes, but home ownership and property tax is what contributes and drives the resources that are available for your education for your children. That we see how all of these policies are connected and helping to drive negative health outcomes across groups. So then when we think about laws, the connection between laws and politics is important, but again, codifying into our laws and into our governance the ways in which certain groups of people can be fully dehumanized and people can be ultimately killed in some of these laws and policies if you are a Black person. And when you couple that with media representation, we have, for example, coming out of a report in New York City that 51% of people who were arrested for murder, assault, and theft were Black at the time that this report was gathered. But at the same time, simultaneously, 75% of the people that local news stations were representing as violent criminals were Black. So we see an overrepresentation of the criminality of Black people, of the utter violence of Black people. And that is a part of a legacy of the depictions of people of color throughout the history of media in this country in particular, and how that then influences people generating or over time developing a lack of empathy for Black and brown bodies when we see them dying or when we see them victimized and when we see them incarcerated. It becomes normalized and part of our sort of subtle subliminal expectations. And so just looking at some of the components of the creation of race, not even focusing on religion, on education, on media, more extensively, but thinking about the ways in which the governing institutions that we leverage to move through our society have been designed from the beginning, have been built not only with racial group inequity as part of the function of the design, but specifically to enhance the economic, political, and social interests of people who are classified as white, particularly at the expense of people who are classified as Black or proximal to Black. And so then the more that you see more immigration of people of color, you see the ways in which Latinx groups, particularly Afro-Latinos, experience proximity to Blackness that hyper exposes them to trauma through these mechanisms as well. And keeping in context the time record of this. So oftentimes people want to distance ourselves from things like the worst aspects of our history. Slavery was a long time ago. And, potentially from your perspective, you might see it in that way, but the proportion of time that people of African descent have been on this land, over 61% of our time was during enslavement, chattel slavery, right? Even if you were born free in the North, for example, you could be kidnapped by slave hunters and catchers and enter back into slavery. Then we have almost 25% of the time that Black folks have been on this land was during second-class citizenship through the Jim Crow era and through lynch law, right? Where the constant fear of potentially being kidnapped and found dead, hanging from a tree or maimed or mutilated was a function of the daily life of Black people for 100 years. We had a little bit of time, you know, post-civil rights, but shortly thereafter, the war on drugs became an attack on Black and brown inner city communities. When you then think about that in contrast to the opioid epidemic that has largely impacted white and suburban and rural communities, you see that those folks are met with compassion, with opportunities for rehabilitation. We want to, you know, decriminalize and destigmatize those addictions. And we didn't see that. And we continue to have people incarcerated because of the impact of the war on drugs. And so thinking about those many, many years, the majority of our time here being wrought with subjugation, both interpersonal, institutional, and structural subjugation and dehumanization, the impact on our mental, physical health, as well as how we move through the systems that perpetuated those inequities is important. So I'll touch briefly on some of the ways in which healthcare has helped to drive this pandemic of structural racism and the implications it has on communities of color. And so COVID really just being the most recent symptom of this ongoing onslaught that leverages the healthcare system to perpetuate racial group inequity, subjugation of people of color, and to the benefit of people who are particularly white, land-owning, you know, people with money. That, you know, during the 1800s, that those folks who were not white at the time, Irish people, Jewish immigrants, were blamed for and stigmatized for infectious diseases. Chinese immigrants being associated with the bubonic plague, you know, various ways in which our medical model and our approach to addressing population health has historically and consistently included scapegoating already marginalized groups of people, blaming individuals and communities of color, even if at the time that color included people who were not deemed white, yet are white today. And so we really have to keep in context the ways in which we have a pattern within our systems of highlighting the communities who are most negatively impacted, blaming them, putting the onus on them to repair the damage that really our institutions and our systems of governance should be equipped to be able to address. Particularly within the COVID context, keeping in mind that disproportionately people of color, women of color, are likely to be essential workers that are at risk and are taking on that risk in order to maintain their jobs, take care of their families, and serve our communities. We also have that the health systems have been less likely to refer Black folks, Black patients for testing for COVID, thereby having people be more likely to get sicker before they are confirmed, and also plausibly exposing the people within their households. When we have people of color, low-income people, more likely to have multi-generational households and many people within a household, that lack of infrastructure and that failure of our healthcare system really is contributing to the responsibility for driving the disparities. And so how can our present healthcare system really successfully care for Black patients and patients of color when we know that, particularly for Black patients, Black folks receive better care within the healthcare system when they see Black healthcare providers, but only 5% of healthcare providers are Black. Hospitals are being closed in traditionally Black neighborhoods, and that has a historical legacy that when public health responses look to blame patients, they tend to do so and focus on individual behaviors rather than the structural drivers that really contribute to the behaviors that people are able to manifest in the midst of a pandemic. And when our history of our system of healthcare practice is based on abuse and exploitation, and that has not been rectified, and that certainly has not been repaired. I also, in light of the last few months, but also the legacy of which we are the most recent chapter, I want to also focus on this element within the pandemic of racism, that is structural racism within policing and mass incarceration, in honor of George Floyd, Breonna Taylor, Ahmaud Arbery, Trayvon Martin, Eric Garner, the list goes on, unfortunately. I think it's important to really name this component of what Black and brown communities have been carrying and screaming for attention for in the midst of these other overlays of pandemics towards our health specifically, but also just structural racism across all of our governing institutions. And so understanding that in the historical context of the evolution of slavery, that the 13th Amendment was codified that offered that slavery was abolished except as punishment for a crime whereof the party shall have been duly convicted. And so once we had this clause that allowed for the perpetuation of slavery as long as a person is convicted of a crime, well, then we start seeing the creation of Black codes, which are laws that are really only laws that Black people are going to be policed for and able to commit. For example, post-emancipation, a Black person could be stopped and asked to show evidence that they have a job. Well, if you just were emancipated from slavery a month ago, a year ago, what jobs were there aside from, sharecropping, which is essentially then having to pay to be enslaved on a plantation you might have formerly been a slave to. And so this idea that mass incarceration, incarcerating people who have historically been unwanted, unvalidated, except for the utility of their labor. We start to then see minority neighborhoods being characterized by high rates of poverty, joblessness, that then are factors that can drive the commission of crimes, particularly property crimes, not necessarily violent crimes, but also disproportionate rates of police surveillance to then drive incarceration. And so when we think about that young, poor men, Black or white, were less likely to be involved in crimes in 2000 than in 1980, despite the fact that the rates of incarceration, particularly since the war on drugs, exacerbated tremendously. And that's also true for Black women, and in the last few years, particularly for Latinx communities and immigrant detention centers being of the fastest growing industries in our country, right? One of the top 2 fastest growing industries is kidnapping and detaining people and having them in these cages at the borders. And so one really important component to structural racism driving mass incarceration is that of the war on drugs. Again, thinking prior to the current opioid epidemic, that when we had drugs flooding into Black and brown communities, the incarceration rates, rather than treatment rates, rather than mental health care services being made available, incarceration rates exploded. And so drug offenses accounted for 2/3 of the rise in federal inmates and more than half of the rise of state prisoners between 1985 and the year 2000. We saw that most people in state prison for drug offenses had no history of violence or significant selling history, which has led to the US holding more nonviolent citizens behind bars in the 21st century than any other period in American history. Then when we think about overrepresentation, not only in, we have overrepresentation in arrests, in sentencing, in death penalty, in solitary confinement, in every aspect of incarceration, we see overrepresentation based on race in patterned ways. And so from 1995 to 2005, although African Americans were only 13% of drug users, they represented 36% of arrests and 46% of those convicted for drug offenses. Again, and that's using not even necessarily sales. In California, if you look at the 25 most largest cities, Blacks were arrested for possession of drugs at 4, 5, 7, and up to 12 times the rates of whites. Again, although the fact that Black and brown folks report less substance use than white counterparts in most studies. A significant driver of arrests in many large cities is that of the policy of stop, question, and frisk. And so the ways in which institutions, police districts, police departments might be leveraging this kind of policy as a function of institutional racism that we need to really scrutinize. So between 2002 and 2011, Black and Latino residents in New York City, where stop, question, and frisk is practiced, were stopped. 90% Black and Latino residents were 90% of the people stopped and frisked, while 88% of people who were stopped and frisked were innocent of any crime. So you see the massive overlap of people who are innocent, but just because largely they're Black and brown and they fit some suspect profile that's abstract and vague, they're being stopped, they're being detained, they're being harassed, they're being embarrassed, they're being traumatized. And although Black and Latino males between the ages of 14 and 24 only account for 4.7% of the city's population, they accounted for 41.6% of stops in 2011. And if you think about the cognitive development of children, children ages 14 to 24, it's only until 24 years old that your brain fully develops. So while we have young Black and Latino males who are in prime elements of their cognitive development, they are experiencing significant trauma from policies like this, such that the number of stops of Black men exceeded the entire city population of young Black men in New York City, which means that most Black men in New York City can expect to be stopped and frisked, and possibly significantly more than once. And so then when we look at the big picture of the rates of incarceration, 1 in 36 Latino males can expect to be incarcerated in their lifetime. 1 in 15 Black men are incarcerated, compared to compared to 1 in 106 white males of adult age. And between 1970 and 2000, every state experienced an increase in incarceration of at least 150%. Then when you expand our notion of who is, being impacted by this expansion, this evolution of enslavement through incarceration, you then have how many people are subject to the state because of this system of policing, and subjugating people based on their proximity or assumption of criminality. So not only are there the 2.2 million people who are incarcerated, but how many people are accountable to the state through the parole system, through the probation system? Upwards of 7 million people. And so when we contextualize that within the framework of racial trauma refers to the stressful impact or the emotional pain of one's experience with racism and discrimination. And having that be paralleled with the impact of historical trauma, which is defined as an event or a set of events that happen to a group of people who share a specific identity. And that individual trauma becomes collective as trauma continues to happen generation over generation. So you can imagine how historical trauma is evident in indigenous populations, where you see not only did the Trail of Tears and mass genocide happen, but the ongoing subjugation of the descendants of that trauma. The same with the descendants of enslavement, similar to the descendants of the Holocaust, for example. And so the growing field of epigenetics is helping us to understand the ways in which our social experiences cultivate manipulation within our DNA, our genetic makeup, so that when we are exposed to chronic stress throughout our lifetime because of poverty, because of discrimination, because of segregation, and through the trauma that our ancestors experienced, it produces mutations in our DNA that can prime future generations for healthcare inequities and disparities. So when we think about, that might bring up for people post-traumatic stress. And so I think there's a significant parallel in looking at racial trauma and historical trauma and how we understand post-traumatic stress. The issue is that for people of color, there really isn't a post component because the stress and the trauma persists throughout our lifetime, and so far, is expected for our children as well. But post-traumatic stress speaks to the development of response, a stress response to a given event during which an individual feels extremely fearful, horrified, or hopeless, and is characterized by persistent re-experiencing of the event, persistent avoidance of stimuli associated with that event, and emotional numbing, hyperarousal, and a variety of other symptoms that can manifest. Now, again, when you think about the ongoing experiences of discrimination, of trauma, of secondary trauma from witnessing people who look like you being killed on our news feeds every day, that post component isn't exactly relevant. But many studies have found that discrimination is significantly associated with post-traumatic stress disorder symptoms, and that participants in studies who've experienced any discrimination were significantly more likely to screen positive for PTSD. And that, racial trauma very much parallels with the symptoms that can manifest that reflect post-traumatic stress as that of people who have experienced sexual trauma, because it's an assault on the personhood and the integrity of the victim, including, grave physical violation of their body, of their vessel. And that exposure to violent crime is more likely to occur in disadvantaged or vulnerable or marginalized or oppressed communities, and that living in an environment of poverty and violence can worsen the pre-existing depression or trigger the onset of new depressive episodes for the people who are primed in those communities for that trauma. And so thinking about some of the symptoms that manifest with racial trauma, that, stress is the body's physiological and cognitive response to situations that are perceived as threats or challenges. And it's normal, it's a natural response for the body to have. But most stress that individuals encounter on a day-to-day basis is tolerable. A fear that arises or an incident that might occur in a rapid succession and then move on. But because individuals have coping skills and supportive relationships that help us to endure it, our bodies are designed to have a stress response that includes a chemical response that helps to mitigate the flare-up that comes with stress and that comes with those moments of fear and trauma, but it's supposed to dissipate. And so when people are being born into stressful conditions of poverty, of subjugated, inadequate housing due to histories of housing inequality and policies that create ghettos and that create inadequate housing for people of color, when we then continue to experience racism and microaggressions in our workplaces or, in our communities, again, discrimination on the internet and through the secondary trauma that we see in our news feeds, communities of color are hyper exposed and primed to manifest a variety of not only psychological and physiological responses and symptoms, but also maladaptive coping mechanisms. When we look at the design of our communities and the communities that are most primed to show depression, anxiety, fatigue, are also more likely to have liquor stores than banks, right? Liquor stores than grocery stores with fresh fruits and vegetables, having increased addictive behaviors. And then we see, from the 70s, a flooding of drugs being presented into low-income communities. That also manifests in actual development of chronic conditions like hypertension, like heart disease, and others. And in 2018, a study found that 50% of African Americans who were surveyed had been exposed to one or more killings of an unarmed Black man in their state in the previous 3 months. And that this exposure led to 2 additional days per year of reported poor mental health. In contrast to white respondents who reported no discernible effects due to their exposure to police violence. And so keeping in mind that secondary trauma that we are experiencing, even if it's happening through our newsfeed, contributes to post-traumatic stress, racial trauma that is persistent, how that influences our life course opportunities, especially as it manifests as a symptom of ongoing institutional and structural inequalities for access to jobs, access to other opportunities. Those secondary mental health disorders, how that drives suicide rates, and other forms of impaired functioning and general health problems for individuals and for communities. Then when you land that on COVID, we can start to see how, particularly how communities of color who, because of structural racism, have been concentrated into poverty and into inadequately housed, subjugated communities that lack resources that promote health and positive health outcomes, that you would be able to predict, the disparities in infection rates and deaths in something like COVID. And then we have some of the barriers to addressing these issues. Many clinicians are underprepared to address cultural issues due to social taboos around racism, our lack of development in our formal education to just talk about it, let alone identify and mitigate that racism, discrimination, and white privilege. The psychological difficulties that are attributed to racist incidents are often questioned or minimized. So when people of color do express, I'm having these experiences with racism, I'm running into what seems to be bias based on who I am, we get invalidated. We get called being aggressive or being angry. Many minorities experience cumulative experiences of racism as traumatic. Again, it's not something that happens once and then it's over. It's the conscious and visual and unconscious, more subliminal exposures to racial trauma all throughout our lives. And even currently, the DSM-5 does not recognize racial trauma as an acceptable traumatic experience for diagnosing PTSD. So when we're seeing on a weekly basis more and more Black bodies with knees on our necks, with gunshots in our backs, there is no mechanism for diagnosing the ways in which that is deeply and particularly impacting people of color, markedly in ways that it doesn't affect people who don't identify with the bodies that we're seeing in these streets. And so thinking about some actions, certainly in the 50 minutes I have, not a comprehensive list of what we're going to do to erase racism, but some things that we can do as individuals. Increase our self-reflection on how we've been socialized. Who are we exposed to in our upbringing and who were we not exposed to? Look back at your favorite books as a child and see who was present, who was not, who were scientists, who were thinkers, and what did that teach you about who was not made visible, and the stereotypes that we've adopted. Utilize the implicit association test and learn how to question and be more mindful of our gut reactions. Seek out training and coaching. Increasingly in this time, we've got anti-racist educators, activists, coaches who can really help you to develop your own awareness and skill set for interrupting bias in your own life, in your own consciousness, but also in the institutions where you make money, and where you, interact and interface with the community, so that you can develop an anti-racist lens that's action-oriented so that we can work together to dismantle these systems. Commit to allyship and accomplishship and interrupting bias on every level. And certainly learning the context of the community in which you serve. Now, specifically, healthcare providers can also ensure that they're cultivating an understanding by educating themselves about systemic racism and about the biases that are very clearly and empirically being measured in healthcare practice. Put yourself in spaces, particularly outside of the workplace, where you can really learn more about racism, not only from those who are experiencing it because you want to be mindful of not taxing people who are having to live with this, with then being your educators. But there's online trainings, there's opportunities like this where you really can learn from people who are living with it and conscious of how to navigate and ultimately have recommendations for dismantling these systems of oppression. Develop trainings and make sure that all staff and faculty, care providers are trained on trauma-sensitive care, because this experience with racism and discrimination is a significant form of trauma. And commit to taking insurance and or offering mental health services on a sliding scale as we understand the relationship between race, socioeconomic status, and the mental health implications that people are carrying for generations as a result of that imposed intergenerational poverty. And then on a larger level, one very small lens of actions includes, offering more mental health services and screenings in low-income neighborhoods, really honoring that relationship between the negative mental health implications for concentrated poverty and for racism and discrimination. provide crime victim services to help educate, support, counsel those who have been impacted by exposure to violence, making sure that in our research that stigmatized minorities are included in clinical trials, which is going to have to address some of the historical marginalization and trauma and oppression that came from research and came from higher education and healthcare systems. And making sure that white clinicians are well trained in anti-racism, allyship, accomplishment, but ultimately we've got to recruit, educate, and employ more providers, psychologists, counselors of color to fill the gaps that we've inherited. And in 50 minutes, I've done it. So I look forward to the question and answers. I thank you so much for the time that you've allowed me to guide us through this context, and look forward to what as a community and as a generation we are going to do to leverage this moment and this opportunity for transformation for all of our communities. Thanks, everybody.
Thank you, Sharon, so much for joining us today and for being part of the series. I think I can speak for everybody that this is just such a great way to close off our series and to really get people to not just really think about these things and do the reflection, but also that last bit where, you know, we're offering, actionable steps that people can take on an individual basis to tackle racism and bias, and specifically in healthcare. So thank you so much. We will jump right into the Q&A. So for folks that have not joined us before, you can use the Q&A section in the bottom of your screen, and you can insert your question there. If you're interested in asking your question live, you can do that by using the raise hand option, which is also at the bottom of your screen, and we will call on you and unmute you so you can ask your question. We'll start with some of the ones that folks submitted a little bit earlier in the Q&A section. So let me pull those up. Okay. So we have a question earlier that we got anonymous. This person is asking, do you have examples of how an organization, maybe one that you've worked with, has been able to shift to best address structural racism? What I find in organizations is several presentations and talks about racism, but no systematic change.
Yeah. So one example of really working to apply an anti-racist, anti-oppression approach to something that is an institutional policy or practice. Here within the Santa Rosa Family Medicine Residency in the last couple of years, they have shifted in their selection process of how do they vet applicants who want to become residents within this program, and move that from something that a small group of just faculty review and make these important decisions to something that becomes a redistribution of power and a redistribution of agency and the ability to influence that very important decision making. What they did was created a committee, a selection committee that included residents, that included staff, that included faculty. They assessed the rubric that was being used for quantifying and sort of measuring the expectations of applicants. They redistributed their expectations from moving away from standardized exams, which we understand are racially biased. These kinds of national awards that we understand that come from medical schools that oftentimes marginalize people who might have experiences of being, from low-income communities or, lacking academic support or single parents, etc. So really removing some of the weight and the magnitude that some of these biased tools have historically held. They buffered that power dynamic and power imbalance by minimizing some of the weight that went onto those aspects of people's applications, and included a process of having this selection process that people went through to be very inclusive, being open, being transparent, transparent, allowing people to be able to scrutinize and make changes. And I think that that has produced not only some really extraordinary classes and cohorts of diverse residents, but also has created some cohesion where people who were of marginalized identities really got to feel included, they got to feel heard, they got to feel more trust in the process that these leaders were adopting and integrating into the process of this institution's functioning. And it wasn't something that was like a one-time try. It is now an institutionalized practice that is to be expected every year. And so I think that's an important example of moving from let's educate people or we'll do some trainings to let's change the ways that our policies and our practices function so that they're transparent, they are more objective, they have been rigorously scrutinized for having components that are wrought with bias being gatekeeping mechanisms that might keep people with lots of skill, lots of ability from being able to access opportunity.
No, definitely. And I think what you're saying is, makes total sense, specifically in, that collaborative nature of it. I think that's such a great way to think about it, especially when you're talking about like moving beyond some of these trainings or classes or even sometimes videos, because on one hand the information is out there, right? But it's how you're able to use that information and how you're able to change some of these policies. And it's innovative work, and it's sometimes frightening because it's sometimes things that haven't been done, but you just kind of have to trial and error it a little bit. And in the process, something great can happen. And, I think that's how we can move forward. Definitely. Thank you. So we have a question. So this was from someone a little further back. So this is when you were talking a little bit about the war on drugs and healthcare and stuff. So this question is from Helen. What about the prison industrial complex evolution from the war on drugs? The concept of war and violence as a mindset is very important in the approach to dealing with health and disease. How do we form these large belief systems, and how can we alter them now? I think you kind of answered it a little bit right now, but I think it's something that is still very daunting for people, right? Because it's this really big system, and how do we begin to change it? And I don't know if you have any insight on how folks can maybe reframe that thinking.
That is so deep and complex, and thank you for asking the question. If you think about the formation and the history of this country, there is not more than a handful of years that this country hasn't been at war. And so really being able to name the intimate, like integrated identity that America has with war, so that when people want to scrutinize your national patriotism, they'll oftentimes say, support the troops. Don't kneel during the Pledge of Allegiance or during the anthem because you're not supporting the troops. Well, why do we have so many troops that are at war, right? It's not like we are talking about supporting the people who go out and like serve the world as volunteers, or like supporting our healthcare providers. This idea that our identity as a nation is so wrapped up in war, in violence, in guns, that even to get, the children who have survived school shootings to try to get some like common sense gun legislation passed is really competing with people's sense of nationhood. And so really being able to name and unpack and deconstruct this relationship that our country has with war and with violence is so important. And being able to appreciate the ways that many times increasingly privatized prisons, one, are contracting with states, so that if a state's budget is floundering, one way that they can help to mitigate that budget is to allow a private prison company to purchase their state prisons. Part of those contracts are sometimes including the state committing to keeping 90% of prison beds filled, 100% of prison beds filled. How can you promise that? how can you promise that there will be crime being committed that will allow you to keep prison beds filled? So then you're feeding this, unspoken quota system of having to stop, question, and frisk people, arresting people for having a $10 bag of weed when that should be a ticketed offense, and not something that people get locked up for the weekend for. But it's happening, right? And so when we then are leveraging, private prison labor for things like creating the kinds of materials that the military uses, like who makes all the vests, who makes all of the, arms, who puts those things together, oftentimes, low paid or unpaid prison laborers. And then having that private prison labor being able to be, paid for by Victoria's Secret, by Dell Computers, using, low and unpaid prison laborers. So this relationship between, war and violence, so that dominance can be perpetuated around the world, and how we leverage incarcerated people, disproportionately the descendants of enslaved Africans and indigenous people to what is now Mexico, as the bodies that make up that labor force, is a very massive, body of identity that we need to start naming and resisting, right? So I think the more that we as lay folks that are going to go vote, in all of our elections, become more educated about the relationships that are held between these institutions and these systems that thrive on violence, right? That thrive on trauma, that thrive on pharmaceuticals being able to create medications that, offer more side effects rather than investing in prevention, like things that are disproportionately ravaging communities of color, like HIV, like COVID. These things can be prevented. We can create a more prevention-oriented healthcare system, but that is not what is most profitable. And we don't count health as part of our gross domestic product, right? We count drug manufacturing, we count gun manufacturing, we count the products of war as part of our gross domestic product, but we don't count the education of our children as a high value quality that we should be investing in. And who should be changing that but us, right? I try to encourage, when I get to talk with young people and with students, don't just vote, we need to plan to run, right? Every single one of us should really position ourselves to be educated enough to be called to action, to serve our communities and be civically involved. But in the last 20 years, lots of our schools, especially low-income schools, don't even have civic engagement as a class to learn how these policies get made, let alone changed. So I think really finding our own empowerment in these solutions is something that we have to reclaim and own, because yes, the legacy of war, the legacy of incarceration and slavery and subjugation and disease is a big one. But people created those processes. People created these ideas, and it will be us as people to change them, in my opinion.
No, definitely. And I really like how you ended that. These aren't just things that were dropped from the sky and happen to exist, right? These are things that were made by people, and people will change them. And, specifically, I wanted also just briefly speak to the folks that on here that are what we consider the professionals, and the folks that have their degrees, and who are maybe on this webinar. When you're talking about the youth, definitely connecting with them and creating that mentorship, because at the same time, although we would want to keep this work going for the next generation to make these changes, we should also offer a guiding hand, and not just to the top of the class kinds of students. There's so much potential in all kinds of youth, and we should really invest in that. So I guess that's just my side comment, my call to action to some of the professionals that are on the webinar. And for folks who might be a little bit overwhelmed or want to know a little bit more about what Sharon mentioned at the beginning about the prison industrial complex, I'm rereading Are Prisons Obsolete by Angela Davis, and that is a very short read, very easy to digest. So for folks that want some more information, I definitely recommend that book to start. So let's jump into a few more questions. These questions are a little bit more on specific stuff. So We just got a question from Sarah. Are you in touch with the county about the upcoming recruitment of the permanent equity officer role, which has been filled on an interim basis, and or have you sent your own recommendations for the county or how to shape this position? Maybe how can other people get involved for recommendations?
Mm-hmm.
Do you know anything about this?
I have not been directly involved in this equity officer role. I mean, I could probably come up with a slew of suggestions, but I really think that the people who are shaping that position, as well as the people who know that they're going to be served by that position, should really be involved in defining what the needs are. I myself, I'm like a temporary transplant within this community. I've been here for a year, and I'm heading back to the East Coast in less than 2 weeks. And so, you know, it wouldn't be my call to tell members of this community what the leader of shaping equity for your future should include. But I do think that each individual, like whether you're a professional, whether you're currently unemployed, whether you're a young person, should feel entitled to being able to offer what is your vantage point and your perspective on what equity should mean here, what the gaps are, and you know, how you would like to be served through this role. And I think that that's something that largely we move through our communities in a very disempowered way, from knowing that we should be shaping the roles of the people who our taxes pay to be of service to us. And I think that's missing in this kind of debate and discourse around defunding the police. And if communities are saying the way that you are policing our communities is harming us, and we don't want that, there should be a humility there. I think there should be a listening, you know, that should happen from that, rather than this entitlement to be able to dominate in the way that you want to because you're the one with the title, right? And so I think, you know, reconnecting with, we're doing this experiment of democracy that you could argue has never actually happened, because we vote for a very small privileged minority of people to then like do stuff for us. We don't contribute to most of what happens in our country, and really deciding consciously as a very diverse group of people, how do we want to govern ourselves, right? When we talk back about the what is that war? The first war, the war that got us the to like form this country, the founding fathers and their, you know, resistance to oppression from the British. That, you know, we look at that story and like, yeah, they were entitled to throw that tea off of the boat and like, you know, do these things, but somehow we don't feel that we too are entitled to that, and to that say in the money that comes out of all of our labor, whether it's 25%, whether it's, you know, as a business owner, 33%, or whether it's, you know, however much we are contributing to the resources that go to govern our society and to our communities, like our voice should be a part of that. And I think that the people who are responsible for generating that position should really leverage that and be seeking input from different aspects of your community to define what that role is really going to need to do.
Mm-hmm, definitely. And I, you know, a big part of that is, you know, just this simple like civic engagement, and it can be done on various levels, various amounts. And I think that would be, you know, a great way for some folks to start if they're a little bit curious on how to do that. So we'll go with one last question here. So this is from Daniel a little bit earlier in your presentation. So they're mentioning, notwithstanding the problematic aspect of trying to categorize people into race and ethnicity, is there a recommended list you might recommend for drop-down options that we can use in an organization's intake that is more accurate, specific, and inclusive? For example, to include indigenous people in Latin America as opposed to categorizing them as Latino/Hispanic. Would the census options be a good starting place? I think this is just to kind of get the ball rolling, right? Especially in healthcare and figuring out the language that we need to use, because we know that it'll influence, you know, greater things.
Yeah, that's a great question. And I think that typically the census has lagged behind in representing the diversity of the people. Um, I'm sure that there are some more exhaustive, more inclusive lists that you might be able to find online, but I would just sort of encourage you to also think about, it's one thing to put on your intake forms a better, more inclusive way of capturing people's identities. But then what are you going to do with it? Are you still going to, run people's labs and adjust for Black race? You might have all different kinds of African ethnic identities on your intake form, but are you still going to lump every single one of them together and then adjust for Black race when you measure their breathing through the spirometer or their kidney functioning with the GFR? Is your lab going to adjust the ways in which medicine has largely been perpetuating this false notion of race-based medicine in your risk assessment, in your diagnoses, in your recommendations for treatment? So don't mask your intake form with diversity and inclusion with a really long list of every possible ethnicity and then still run race-based medicine in your labs, right? And in your diagnostic processes. So I'm sure that on the internet you can find probably a couple of options for an answer to your question. But I would also challenge you to question deeply, what then? And what more will you be doing to interrupt the false use of race as a biological measure? Maybe in addition to capturing people's racial ethnic identity, are you also asking people about their experience, exposure to, or perception of discrimination in their life? Or racial trauma, and how that might be interfacing with why they showed up to you with heart palpitations, right? Because it isn't even so much that they're Eritrean and Hausa that's driving their heart palpitations. It's the fact that they look, melanated enough that they were discriminated against by the security guard at the front desk when they got here, that they've experienced it, every day since they immigrated here. And so it's really the racialization, the racial trauma, the exposure to discrimination, and then, the adaptive and maladaptive coping behaviors that might be driving, what it is that's leading them to come visit you. And that's the kind of stuff that within your institution, you really need to be having more critical conversations, establishing some values and expectations, and then implementing those in your institutionalized practices.
Mm-hmm. Definitely. Thank you, Sharon, for that question, for answering, for the session, and for this really well thought out and comprehensive presentation. I think a lot of folks can walk away with really solid language and knowledge in terms of like how to really think about racism and bias and how to apply it in healthcare and everything. So thank you for that. And I think at the root of what you're saying in your presentation and your answers, it kind of comes down to, a lot of reflection and critical thinking. Ask a why, why for everything. And I think if folks can do that work in the different aspects of their life, you'll see that there's a lot of things that we'll find that are a little bit out of place, but also a lot of things that can be changed, right? So thank you so much. This is the end of our not just presentation for today, but for our webinar series. I will hand it over to Daisy, who will speak a little bit about where folks can find the series if they missed any of the presentations real quick.
Hi, everybody. My name is Daisy Cardenas, and I'm one of the coordinators along with Pam Rivas. So before Dr. Enrique brings this to a closing, I just wanted to say a couple things. So thank you, everybody who participated. We will have all the recordings in English and in Spanish on our YouTube page, Latino Health Forum. We already have some available now. If you need any of them before Monday, please just email us at latinohealthforum@gmail.com and I can send you the links, but they will be available in Spanish and English. I will be sending an email newsletter to everybody who attended with those links as well. So they are available. Just please check us out on Facebook as well, Latino Health Forum, if you haven't already done so. And thank you. So now, Dr. Enrique, if you could please close our 7-day series.
Thank you very much, very much, Sharon Washington. It was brilliant. It was really brilliant. I really thank you. And I want to thank you very much specifically because this is the first time that someone has the courage to talk about the Army. The Army is like a sacred cow in this country. People don't talk about it, except to say that they are wonderful and they're defending the country for, I don't know, Nicaragua is going to invade us. Something as an immigrant that always surprises me is when people says, you serve or she served to this country through the Army. If you are a wonderful citizen, if you don't go to the Army, you don't serve the country. We spend $2.5 billion a day. According to the official numbers, 760 billion a year. That's the entire budget of all Latin America. And this is incredible. We have to change this. This is too much. But I heard that you're moving back to the East Coast, and I hope we keep in contact because you will be hopefully a wonderful keynote speaker in our next Latino Health Forum. Thank you. This really was a very comprehensive. In 50 minutes, it's very hard to do this analysis, but thank you. And thank you to all the people that have been participating. Please check with all the wonderful things that Pam and Daisy been doing, so you can have access to the Spanish version of these seminars or webinars and the English version. And we are going to put it in KBBF in Spanish. Well, thank you and take care. Remember, use your mask because till now is one of the few things that we can do, unless you want to drink some antiseptics that might kill you, but otherwise. Please don't forget this. Thank you very much, and we'll see you soon.
Thank you.
Thank you. Thank you.